Hi, I'm Stephen Duckett, Director of the Health Program at Grattan Institute, and I'm speaking to you from the lands of the Wurundjeri people of the Eastern Kulin Nation. I'm going to be speaking to you about big data for health policy and clinicians. And basically, really, I'm going to be talking to you about health policy for policymakers. So here's the slides. And I'm going to talk about strengths and weaknesses and telling the story. But first, some examples, and they're all examples of work we've done. I was interested in ambulance ramping at the Royal Adelaide Hospital. Again, got hold of a big data set about all the patients at the Royal Adelaide 2019-20, found 175 patients who stayed a long period of time, more than 60 days. The thesis is that if you can do something with these very long stay patients, we can improve flow. What we're interested was these 175 patients used up 17,000 bed days. There were 49 patients who stayed 100 to 200 days. They used up 6,860 days. 1,372 patients could have stayed there, could have been admitted to hospital if those patients weren't there. There were 5 patients who stayed more than 200 days. They took up 1,200 days between the 5 of them. You could have admitted 240 other patients. The point of the story, and all of the following stories, is that big data, use of these big data can tell you a story. This one is from work we did in COVID last year. We're interested in modelling what would happen with various effects. We had a data set. We used the Australian population, 25 million people. We knew where they, from the census data, where they lived, where they went to work. We estimated, did they go to school, all sorts of things. And we built this huge simulation model that took hours to run. But basically, we're able to do simulations of what might happen in particular policy relevant effects. And because we did dozens and dozens and dozens of simulations, we could get potential outcomes with a variation between them. So we'd know what would happen if there was good luck or bad luck. And so we had these ranges of the outcomes of different simulations. We're also interested in some work we did the year before using the 2014-15 data set. This was a data set of every patient discharged from every public or private hospital in the country. We're looking at hospital-acquired diagnoses, a diagnosis that takes place, is made after the patient is admitted that wasn't present on admission. And we're comparing that with this designated list of hospital-acquired complications published by the Australian Commission on Safety and Quality in Healthcare and the Independent Hospital Pricing Authority. And there's very, very few of those, but there are lots of hospital-acquired diagnoses. And we were saying, no, obviously not all of these can be prevented by any stretch of the imagination, but some hospitals do better than others. And so what would happen if we got the rate of these down to the rate we see in the best quartile or the best decile? And so we'd significantly have a much bigger impact on reducing hospital-acquired diagnoses. Now, does that matter? Well, yes, it does, because these things cost money. And so we got hold of the National Hospital Cost Data Collection. So we had data on all the costs of patients admitted to public hospitals in Australia, bigger public hospitals in Australia. And so we were able to estimate what is the average incremental cost if you had one of these present, if you had a hospital-acquired absence present, and only 599 of them had that in 2014-15, that would have cost $20,000 for each of those patients. Really big money. Now, of course, these are dramatic, but they're very rare. And so we're also interested in looking at what is the cost of all hospital-acquired complications. And so again, using the same methodology, the National Hospital Cost Data Set, we've got the costs. We can say, does this patient have this cost, or does it have this diagnosis? If not, does it cost more, does it not? And so we're able to show, for example, that infections cost $1 billion in 2014-15. So poor care with these infections cost a lot of money. Now, obviously not all of these can be eliminated, but as I showed a couple of slides ago, you can get some hospitals do better than others. And so in this one, what we're showing here is these small hospital-acquired complications, the infections and so on, post-procedural complications, add up to a lot of money. In fact, $4.6 billion. Then we got the hospital emergency department data set from the ACT and Victoria, and we were interested in the issue of climate change. And this came from our report on climate change last year. And so what we did was we got all of the hospital emergency department data and the air quality data, and we matched them together, and we were able to look at what was the impact on emergency department admissions given the air quality around. Now, no one would say that emergency department admissions cause poor air quality, and so this is probably causal. That is, poor air quality leads to an increased number of people going to emergency department with a respiratory illness. And in fact, we've got a linear relationship there. So this is matching a big data set with another big data set to actually show something about that bushfire smoke, which it was in the Black Summer of last year, or last 2019-20, has health consequences that are pretty direct and pretty immediate. And so the consequences of bushfire smoke are not, bushfires are not only the immediate deaths, but also for health status. So in that very, very quick run through, what I've shown you is using quite different data sets, putting them together in different ways. And so what can you tell? Well, I grew up in a research environment where descriptive was bad and randomized controlled trials good. It's the gold standard. But what I would now say is observational research, which is what we mostly do here at Grattan Institute, is really, really important. It tells you the what, the when, the where, the who. It's hypothesis generation. It's a can opener. It allows you to open a can and say, this looks interesting. Maybe we need to do more research. Sure, causal research, randomized controlled trials, answer the why, absolutely, absolutely imperative. But the big data can tell you different things, and it can help you understand what is actually happening. And importantly, it's really important, this what, when, where, who question, given the state of science. Do we know what the costs of hospital-acquired diagnoses are? Before we did our study, no one had done that in Australia. Do we know what the relationship between air quality and the hospital emergency department is? You know, so there's a whole lot of stuff that we didn't know, these relationships. And this exploratory phase of science development was really critically important, and it's what big data allows you to do. The cost of big data is very, very low. Once it's been collected, you can use it for an analytical purpose. Now, just as you learn about how to analyze a randomized control trial and the epidemiological issues associated with this, with big data, you also need to think about how do you present it. More or less everything you do with big data is going to show a statistically significant effect. So you've got to say, well, what is policy relevant? What is meaningful? And so we've basically, I really think it's important that the data need to be made to speak. And if you remember back to some of these graphs I showed, the headings are really important. The design is really important. I'll give you just one example. Basically, I believe in what's called the interocular traumatic test, the ITT. It hits you between the eyes. And if you can see it in the data, it's probably true. Now, this is some work we did on health insurance. We're looking at what we call the death spiral, the number of people with insurance, younger people dropping out. And you can see there, look at the 20 to 39-year-old age group, proportion of people in that age group with hospital insurance is actually trending down, proportion of people age 65 plus trending up. So it's pretty clear there, not clear enough. This data, this graph was not published in our report. It was one of our process things, one of the things we jettisoned along the way, because this data is exactly the same as this one. In this one, you can see really clearly that the insurance pool is getting older. The number of, this is a cumulative change in the number of people with private hospital cover. You can see what's happening with the 65 pluses, and you can see what's happening with the 20 to 39s. This and this are exactly the same data. this one is so much clearer. So we spent a lot of time at Grattan thinking about how we present things to convey evidence. So you don't need a randomized control trial to know something's happening. So that's my story. Really important to tell the story with big data. The analysis of big data does something different. It's still rigorous, still really important, and is different. But also, you know, big data is everywhere, and people are making up these links between those who buy bananas and those who buy carrots. So thank you very much. That's the end of my presentation, and I look forward to answering questions from you on the panel.